And so this is open to all three of our panelists. And I'll start with the first question. And this is, I'll ask Dr. Johnson to go first, but it is critically important to get the right diagnosis, as Dr. Cubb just said. But in your experience, what are some of the diagnoses that you've seen that can mimic anaplastic thyroid cancer, or where you thought you had ATC and ultimately it was something else?
Yeah, so I think one of the most important clinical differentials is probably lymphoma. Lymphomas can often completely overrun the thyroid, and so clinically, sometimes we'll get a biopsy that's, rush, rapidly progressive thyroid mass or large thyroid mass. Differential includes anaplastic versus lymphoma. It's usually very easy to distinguish those under the microscope, just with our basic stains or a few additional stains to characterize the proteins that those cells express. That said, anaplastic thyroid carcinoma under the microscope is very poorly differentiated, right? So Dr. Cubb described that most of them come from differentiated thyroid carcinomas that have gone bad. And that makes the cells under the microscope look nothing like their normal counterparts. Sometimes, usually we require special stains to determine what these cells express to really be confident in our diagnosis. Sometimes relatively benign or less aggressive thyroid tumors under the microscope can also undergo bizarre changes to the cells themselves. So occasionally we will see an FNA that is called anaplastic thyroid carcinoma or concerning for it, even though clinically it may not make the most sense. And then we get the specimen under the microscope resected, and we can see, oh, this is actually just benign but bizarre cytologic change that we can see under the microscope. Occasionally that might happen. So really using the combination of what the cells look like under the microscope versus in addition to all of the clinical information is really critical. One other scenario too is that sometimes in patients with a very lateralized tumor to the neck, we'll get an FNA, and sometimes those cells under the microscope will look squamous. And so sometimes the differential could be between an anaplastic thyroid carcinoma, which can also look squamous, versus a more common conventional squamous cell carcinoma of the upper aerodigestive tract. Those are probably the most important distinguishers. And then again, as we've harped on so much, necrosis can make diagnosis very challenging. Rapidly progressive or growing lymphomas can be necrotic as well. So sometimes we really do have to get usually have to get multiple specimens, sometimes even three or four times, just because these tumors are so rapid and necrotic.
Yeah, that's really helpful, Dr. Johnson. And just anecdotally, what percent of your patient or specimens that you've reviewed that the clinical suspicion that it was anaplastic thyroid cancer and it turned out to be something else?
Yeah, so as Dr. Cubb said, that there's so much value in doing next generation sequencing on these tumors, and so tumors that can look poorly differentiated or undifferentiated under the microscope, historically we think that all of these tumors are anaplastic thyroid carcinoma. But sometimes it doesn't quite read the book, and so those tumors get sequenced, and we actually identify either a novel fusion between two genes that express this combined RNA that are not associated with the BRAF mutation or the most common mutations in anaplastic thyroid carcinoma. We identify those fusions, and we realize that the tumor biology is actually a little bit different than anaplastic thyroid carcinoma. We recently had a patient who had a fusion in this gene called NUT or NUTM1 that we thought clinically and microscopically was anaplastic thyroid carcinoma, or at least very poorly differentiated thyroid carcinoma that turned out to be driven by a different molecular driver.
It's great. Dr. Blumberg, Dr. Cubb, anything else that you wanted to add?
I think taking a step back, because I normally look to Dr. Johnson to help tell me what this is. So, clinically, what are other things that present like it? So, as he brought up, lymphomas, our clinical presentation for anaplastic thyroid cancer is a rapidly growing neck mass over, days to weeks. When we think of thyroid cancer, whether that's, really well differentiated or even poorly differentiated, typically those grow slowly over time. So the clinical presentation can be very, very different. problem is lymphoma also grows really fast, also can encase most of the thyroid. Um, Oftentimes with lymphoma, you can have over hypothyroidism. That's when someone's thyroid isn't working. So clinically, we could get some clues, but really rely on the biopsy. Other things we can see, other cancers actually go to the thyroid. That's another thing that can be quickly growing and progressive and kind of give you the same clinical symptoms. But our biopsies really help us figure out the difference between them.
Yeah,
The
those
only
great
thing I'll add
points.
is that don't be afraid to suggest to your surgeon to get tissue the old-fashioned way. Sometimes you do just have to go in and sample the thyroid if the diagnosis continues to be unclear. Oftentimes this can be done if a tracheostomy is being performed, or even if it's not needed, just an incisional biopsy is sometimes important to get the diagnosis. We don't like to do surgery in that context if we don't have to, but sometimes it's required.